Hello and welcome to MedTable Talk. This is the first of 3 episodes where we candidly discuss the latest developments of B-cell maturation antigen, or BCMA, directed therapies, challenges, and offer practical tips to apply to these novel therapies in relapsed refractory multiple myeloma. I'm your host, Melody Smith, and I'm an assistant professor and physician scientist at the Stanford University School of Medicine. I'm happy to be joined by my esteemed colleagues, Adrienne Phillips and Paula Rodríguez Otero. Adrienne, can you go ahead and introduce yourself?
Thanks, Melody. My name's Adrienne Phillips. I'm an associate professor of clinical medicine at the Weill Cornell Medicine New York Presbyterian Hospital campus in New York City.
Paula, can you introduce yourself to our audience?
Sure. Hello, everyone. I am Paula Rodríguez Otero. I am a hematologist working at the University of Navarra in Pamplona, Spain. Very happy to be here with you today.
Thank you so much. I'm really looking forward to our discussion today. And in today's episode, we're going to go through various topics discussing the role of BCMA in relapsed refractory multiple myeloma, an overview of the classes of BCMA-targeted therapies, the latest updates on practice-changing data, strategies for prevention and management of adverse events, and also diverse representation in clinical trials, which is also a very prescient issue. So remember, this is episode 1 of 3, so stay tuned to hear what topics in relapsed refractory multiple myeloma we'll be discussing in future episodes. So, Dr. Otero, we've been hearing a lot about BCMA-targeted therapies and new developments related to this therapy. And the big question is, why are we investigating BCMA as a therapeutic target for patients with relapsed refractory multiple myeloma?
So this is a very important question, and BCMA is a very important target. So first, we know that despite all the advances that we have witnessed in the recent years regarding the treatment of multiple myeloma patients with novel agents and novel combinations that have for sure improved the survival, patients with myeloma continue to relapse, unfortunately, and they become resistant to more and more classes of drugs, and therefore they still need novel agents to be rescued with. So in this regard, patients that fail the classic drugs, so immunomodulatory agents, proteasome inhibitors, anti-CD38 monoclonal antibodies, still have a dismal outcome. So we do need novel therapies, and BCMA-directed agents have been developed first for the treatment of these highly refractory patients. And BCMA is a very relevant target in myeloma for various reasons. First, because it is selectively expressed in the compartment of the plasma cell, so the expression outside this tissue is very limited, and therefore it is a very important or interesting target for drug development. And also because BCMA has an important role in the biology of the plasma cell. So BCMA is expressed in a higher proportion in tumor cells than normal plasma cells, and has a key role in maturation, differentiation, providing a survival advantage for the myeloma cells. So blocking these targets, it really makes a difference in the treatment of myeloma.
Yeah, I think those are all, really important points for us to consider that, the myeloma, especially as we think about potential off-target effects, side effects of BCMA, it's really important that it has higher expression in the myeloma compared to the normal plasma cells. So, as we think about the mechanisms for BCMA targeting in various therapies, there are several different strategies that have been employed. So one is chimeric antigen receptor T-cell therapy, where immune cells, a specific subset of the immune cells, which are the T cells, are engineered to express the BCMA receptor that can bind to the BCMA on the myeloma cell in an MHC independent manner. Another approach is bispecific antibodies or bispecific T-cell engagers. This also works through utilizing both CD3 and BCMA to target BCMA on the myeloma cell. And then the final approach is antibody drug conjugate, using this antibody drug conjugate targeting BCMA on the myeloma cell. As you think about these therapeutic targets, Paula, your thoughts in terms of these targets and their potential therapeutic effects. I think it'll be important for us to kind of think about, based upon the mechanism of action for the way that the BCMA therapy works, we'll have some understanding as to how the patients may respond, the time frame for response, as well as the toxicity, right?
Yeah, absolutely. So there are the T-cell redirected therapies that are, as you explained before, the CAR T, the therapies, and the bispecific antibodies. So these two modalities do work by redirecting or enhancing the activity of the T cells. And then we have the antibody drug conjugate, which is more of a, let's say, a classic drug with an antibody being linked to the tumor cell and then incorporating inside the myeloma cell the cytolytic drug, which in the case of myeloma with the current development is monomethyl auristatin F. So really there are two completely different modalities, but they are giving a lot of good efficacy data for our patients.
Absolutely. Yeah. So we have, as you mentioned, a number of BCMA targeted therapies with multiple mechanisms of actions. So antibody drug conjugates and the bispecifics are off the shelf therapies that are given at repeated interval dosings. They each have unique side effects, which we'll talk about. But when we compare those therapies to CAR T therapies, just like they're given in leukemias and lymphomas or a one-time treatment, and perhaps the toxicity in that immediate period when they're administered is different, notably the cytokine release and the ICANS. Once you get past that period, the duration of effect is long lasting and you're not administering that therapy anymore. Other unique toxicities include with the antibody drug conjugate that's currently available, has a unique ocular toxicity. And both the bispecifics and the CAR T therapy are immunotherapies and depend on your T cell function. But patient's T cell fitness is something that's important to consider with those therapies. So moving on, belantamab mafodotin, which is the first in-class antibody drug conjugate, which was approved here in the United States, I believe back in August of 2020, based on the pivotal results of the DREAM2 study, which was a phase 2 study enrolling 196 patients, and 2 doses of belantamab were looked at, 2.5 milligrams per kilogram and 3.4 milligrams per kilogram. And these were very heavily pretreated patients, and the overall response rates in both arms were approximately 30%. And the duration of response was ranging between 6 and 11 months. And progression-free survival was approximately 3 months, and median overall survival was approximately 14 months. The most commonly observed adverse events were keratopathy in 2/3 of patients, and then thrombocytopenia in approximately 1/3, and infusion-related reactions in about 1/5 of patients. So despite that being the first in-class antibody drug conjugate targeting BCMA that was approved, additional studies showed that the drug did not meet its primary endpoint in the DREAM3 study. And the FDA, at least here in the United States, had asked the company to withdraw the treatment. And based on this not meeting the progression-free survival endpoint, the drug has been taken off the market here in the United States. What's the status of this therapy in Europe, Paula?
Yeah, so in Europe, it's still available. So the EMA has not withdrawn the belantamab from the market. In Spain, where I live, they are waiting for a new revision of the data that is, I think, expected to take place around the spring. So we do not know how everything will look like after this new revision, but there are also, and I think it is important to highlight, that there are other phase 3 randomized studies that are ongoing, evaluating belantamab in combination with other standard of care agents in myeloma. There are the DREAM3, the 7, 8, and a lot of other DREAM studies.
Yeah, I agree, Paula. I think that, as we think about belantamab, this may not be the end of the road for it, because there are these other studies that are coming. And as we all know, a randomized phase 3 study is the gold standard for us to be able to compare new drugs to standard, currently FDA-approved therapies. And so it may be that some of these other studies may help to resurrect this drug in the United States. So now I'm going to talk a little bit about another class of a BCMA targeted therapy, and that is one of our BCMA T cell engagers, teclistamab. So the Majestic 1 study evaluated teclistamab and found that the overall response rate for patients with relapsed refractory multiple myeloma who were treated on an open label study, a multi-cohort single arm study, was 63%. And this was a substantial benefit for patients with triple class exposed disease. So that's patients who've previously received a 3-drug combination for treatment of multiple myeloma. For the patients with their first response, the study noted that the median time to response was 1.2 months, but the best response was 3.8 months. And in terms of MRD negativity, which is the minimal residual disease negativity rate, they found that 26.7% of all patients treated in the population had MRD negativity, which is really encouraging data. So what are your thoughts in terms of some of the implications of this teclistamab data for patients, particularly given that we are familiar with the side effects of teclistamab, and we'll get into that a little bit later, cytokine release syndrome, which was mostly low grade, cytopenias and anemia. What do you think about some of this data, Paula?
Really think that the data is very impressive. So this is the first of several other BCMA T-cell engagers that are being developed, but for sure it's a great step forward. So we get higher efficacy rate in a very advanced myeloma population, with the majority of patients being also refractory to the 3 main classes of drugs. More importantly, I will say the responses are very rapid, which in some of these patients, this is critical because the patients are really sick. So they need really a good and rapid response. And we do see deep responses with over half of the patients achieving very good partial responses. So really the responses are rapid, are deep, and also they are durable, because we've seen in this Majestic 1 trial that the median progression-free survival was close to 1 year. So again, in a population with a median of 4 prior lines of therapy, so advanced myeloma patients. And I think that this is a very important news for the patients with myeloma.
So yeah, Paula, you want to talk to us a little bit more about some of the other T-cell directed therapies?
Sure. So we now have 2 CAR T-cell treatments that target BCMA that are approved both in the US and also in Europe. So we have idecabtagene biclusel, Idecel, which was approved based on the KarMMa-1 trial, which is a phase 2 pivotal single-arm study. And with Idecel alone, single infusion, patients with, again, triple-class exposed relapsed refractory myeloma with a median of 6 prior lines of therapy, had an overall response rate of 73%, with 1/3 of the patients achieving complete response or stringent complete response. So in this study, different doses were evaluated. The target dose of Idecel was established at 450 millions of CAR Ts, and with this higher dose, the outcomes were slightly improved, with a CR rate of 39% and a median progression-free survival, again, of 1 year. So again, we do see deep responses and durable responses in, again, a population of patients with very advanced myeloma. And the other CAR T that we have approved and available is ciltacabtagene autoleucel, also known as cilta-cel, and the approval was based on the CARTITUDE-1 trial. So in this study, again, similar patient population with very advanced myeloma, and I think the data is really impressive, with an overall response rate of 98%, and more importantly, an stringent complete response rate of 82.5%. So this data has never been seen before in such an advanced myeloma population, and this led to a median progression-free survival that is not yet reached, with a median follow-up of that is now over 27 months. So again, very, very impressive data in very sick patients with very advanced disease. And for sure, the safety profile is not nothing. We do need to know and to manage the cytokine release syndrome, cytopenias, neurotoxicity, but for sure, this is a great novel therapy for our patients.
I'm so impressed by this data. The stringent complete response rate of almost 83% is remarkable.
Yeah, absolutely.
So perhaps now we can talk a little bit about some of the new and emerging BCMA therapies for relapsed refractory multiple myeloma. Paula, do you want to discuss some of these newer agents?
Yeah, so there is a lot going on, in myeloma in the BCMA space. There are several bispecific antibodies that are being developed. So the more advanced in the development is elranatamab, which has now completed the phase 2 trial, and the overall response rate is 61%. And the survival data is not yet mature, but for sure, this is another drug to have in mind. And also there are other CAR-Ts targeting BCMA that are being developed, although the data is still quite preliminary.
Sounds good. And we'll definitely delve more into these new and emerging BCMA therapies in our second episode. So more to come there. So I would like to now briefly introduce a guest because we've gone over some of the safety, tolerability of each of these BCMA targeted therapies. And we know that the toxicity profile of each of these therapies is distinct. And it's important to, in the supportive care of our patients, manage these toxicities. So today, in order to discuss this further, we'll be joined by Beth Feynman. And I'd like you to go ahead and introduce yourself.
Thank you so much for the opportunity to speak today. I love hearing this conversation, and I'm so thrilled to be invited to discuss the toxicities. So my name is Beth Feynman. I come to you from the Cleveland Clinic, Department of Hematology and Medical Oncology, and I, on a day-to-day basis, am charged with managing, assessing, and intervening on these side effects. So in my mind, the data show that there are really two distinct side effect profiles, as you mentioned, Melody, a moment ago. Really, the anti-BCMA off-the-shelf ADC belantamab is totally separate. It's convenient. Once every 3 weeks dosing. You don't need to pre-medicate patients. They come in, get the infusion, and go home. However, there was a high incidence of keratopathy, which was mostly microcystic-like changes and decreased best visual acuity, which prevents some patients from taking the therapy in the first place. I do still have patient on compassionate use, belantamab mafodotin, so it is still a perfect option for some patients that have had previous treated therapies. The other bucket is the CAR T cell and the bispecific T cell engagers. These require hospitalizations. Cytokine release syndrome, we know how to manage, we'll discuss in a moment, but they encompass a lot more discussion. You need to have a caregiver support. It's not just come into the office every 3 weeks, but it does represent a very effective therapy for patients that have had heavily pretreated relapsed refractory multiple myeloma.
You alluded to the cytokine release syndrome that we see with the bispecific T cell engagers. In terms of the toxicity management of that for the CAR T cells, some distinctions there that you might want to highlight.
The prolonged cytopenias, I really am concerned about. We'll discuss strategies in a few moments of what I use, but primarily the cytokine release syndrome tends to be mild or moderate in a majority of patients. Again, this is really related to the CAR T and the bispecific therapy. One of the things I'm observing is having participated in the clinical trials with people receiving these drugs, we have a nurse, data manager, all these strategies in people that are discussing side effects, planning hospital admission, caregiver support, transportation. All of these things need to be done in standard of care therapy that aren't always thought about. The CRS, although mild to moderate, mild is a mild temperature greater than 100. We give tocilizumab and dexamethasone right away, not dexamethasone for CAR T because you don't want to worry about the CAR T cell fitness or expansion, but definitely for bispecifics. The other thing with the CRS syndrome that I see is that even moderate can be very emotionally distressing. They're requiring oxygen, they're feeling sick, and the counts drop rather rapidly. So now you're neutropenic, so you have to do the infection workup, initiate antibiotics, which can sometimes lead to a prolonged hospital stay. In terms of the neurotoxicity, the immune cell effector neurotoxicity we see, again, we're checking the ICE scores. We have validated tools on the inpatient setting where the nurses or support staff or physicians will regularly check every 8 hours for can you go backwards from 100 to 0, mini mental status type examinations, and really intervene with the same drugs if they have this. And then finally, with the prolonged cytopenias, I have had patients that have had CARs like last year and their platelets are still below 50 and they still require intermittent transfusions. We try to optimize that with romoplastin, erythropoietin, erythropoiesis stimulating agents and trying to avoid the transfusions unless they're symptomatic, because you worry about iron overload in some of these individuals.
I was actually going to ask you, Beth, in your practice, how do you counsel your patients? So we know that for CAR T cells, at least for the initial treatment, patients are admitted and observed for an initial, generally about a week to assess for toxicities. But when patients are in the outpatient setting, how do you counsel them to identify and be aware of these toxicities so they know when they need to contact their healthcare provider?
Right. So, in my institution and many institutions in the United States, our model is that the cellular therapies, bone marrow transplant, are still under the bone marrow transplant cellular therapy bucket. So, that's really a long journey. Patients need to have good enough disease control to be able to harvest their cells and then with the antiviral vector manufacture the cells and then be reinfused 6-8 weeks later. So this is a process. They need a caregiver, lots of trips to the institution, and we really worry about T cell fitness in these heavily pretreated patients. And that's different than the bispecific antibody. So we counsel them about that method and then the bridging therapy. But with the bispecific therapy, a lot of patients don't want to be admitted to the hospital 9 days, which is what many institutions among the United States since the FDA approval in October are doing, because a majority will get at least grade 1 CRS. And depending on when you administer that drug, it happens at 1 or 2 in the morning. So you don't want your patient in the outpatient and struggling with that. So again, lots of education about you can get sick, but until it really hits them and they are febrile and in the hospital for a prolonged time, they don't realize how sick they can get. I emphasize the benefits of disease control, though, and that we know how to manage these side effects.
I just want to get back to this kind of inpatient stay, because I've taken care of a lot of CAR T patients that, have CRS or ICANS at various intervals. So, Melody, I heard you said about a week. Beth, I heard you say 9 days. Is any of this standardized? Is there like a period where you can say, okay, this toxicity is passed, the patient can be discharged?
Right. So in the clinical trials, it was a little bit different, but with the FDA approval and the prescribing information for teclistamab, there's this REMS program that mandates 48 hours observation after the dose. So if you give dose 1 with the step-up dosing, you might not see at the very little, what I call the baby dose of teclistamab, you might not see a CRS incidence with that dose, but in some patients we've treated about 18 patients since the approval in October, outpatient, and I think we've only had about 2 people that have been able to be discharged before that 9-day stay, because that dose number 7, you still need 48 hours observation, which is where we came to that 9-day number.
Paula, I'd love to hear if in Europe that management in the inpatient setting or outpatient setting is distinct from what we've mentioned thus far.
So unfortunately, in Europe, we do not have yet any. I mean, teclistamab is approved by the EMA, but it's not yet available in the majority of the countries. So we have had access to the expanded access program, and the hospitalization is as per investigation discretion. So there is not a mandatory hospitalization stay. Although I agree with Beth that until you get used to the CRS onset and all of that, maybe it's reasonable to keep the patients in. I think that something that is important to highlight is that the CRS is rather predictable. So it appears like a median time to 2 days after the first doses. So it's something that you can expect that it will happen. So patients can be reassured that this is something that we are waiting for. And it for sure, it does require all this organization in the hospital. And I will also take the opportunity to ask Beth, what is her experience with infections? Because the infection problem has also risen as we get more follow-up of all these studies and all these drugs. And what is your opinion? What is your advice to all of us and physicians treating patients with bispecific antibodies, particularly?
Right. Thank you for this important question. Prophylactic antibiotics are used quite regularly. Many of these patients have hypogammaglobulinemia with serum immunoglobulins of maybe less than 400. So we do IVIG. Everybody is on acyclovir prophylaxis. And the International Myeloma Working Group in February of 2022 put forth a paper and consensus guidelines that suggest stratifying your patients into low intermediate, and high risk, and with recommendations as to what antifungal, antiviral, or antibacterial prophylaxis is recommended. And that's what I do. So the future is bright for patients with myeloma. Thank you for allowing me to participate in this rich discussion.
Thank you, Beth. We really appreciate your time and your expertise that you've shared with us and our audience. So now, as we think a little bit more about some of the clinical trials that led to the approval of these drugs, we may want to take some time to think about the enrollment on those clinical trials and understanding how the populations that have been enrolled on these clinical trials for the approval of these drugs, are they representative of the audiences or the patients who have multiple myeloma that these drugs will ultimately treat. Adrienne, do you want to take some time to discuss this a little bit in terms of clinical trial representation and specifically representation of underrepresented minorities in these studies?
Yeah, that's a topic near and dear to my heart because we've made tremendous progress in these BCMA-directed therapies in multiple myeloma, which I don't know if we mentioned at the start, is a disease that is twice as common in African Americans compared to whites, at least here in the
Correct.
United States.
Yes.
So it's amazing that we have these new novel treatments, we're improving survival, but when you look at the clinical trials, particularly of these BCMA-directed agents, and their eligibility and their enrollment, if I could summarize, there weren't that many African Americans enrolled on these trials. And we'll be devoting another episode to disparities in care and the barriers to access to clinical trials. But this is really just a start. We need to make sure that all of these treatments reach the target audience that will benefit from them. And we'll all be able to strategize, and we'll have an invited guest to focus specifically on how we can improve access to these novel treatments for all.
Thanks for bringing up that point, Adrienne. I think it's really important to think about how these studies, the clinical trials, are potentially misrepresenting or underrepresenting the populations that will ultimately benefit, specifically African American patients who unfortunately have such a high incidence of multiple myeloma, as you mentioned. Yeah. Now, as we wrap up this first episode of MedTable Talk, I think we've had a really robust discussion about various BCMA targeted therapies. And I'd love to end with what we'd like to see in a perfect world based upon our discussion today. So, Paula, could you give us some of your reflections about what you'd like to see with these therapies in a perfect world?
Yeah, so it's always difficult, to make this kind of conclusions. But I think that I would like to see first these drugs being used in a best way. So eventually, as we were discussing, in a fixed duration or in combination in earlier disease settings with a good focus on safety as well as with efficacy. And for sure, coming to the last point that we were discussing, I think that it is important to expand the access to both clinical trials and to the drugs once they are approved to all patients and all populations to really reflect the needs that we have in the society to get homogeneous access to the drugs to all patients. Adrienne, what will you want to see in the future?
So, in a perfect world, I would also like to see these highly efficacious therapies delivered to the patients who most need them and can most benefit from them. And certainly, this is very promising initial research. But again, in the real world, if it doesn't reach the patient in the middle of the country who doesn't have access to a cellular therapy center, who's going to get it as a 10th line of therapy, then it's really not doing its job. So, in my perfect world, I would like all patients to really have access to these great treatments.
I definitely echo both of your points. I think in a perfect world, I would like to see a bit more information targeted to providers to help guide their clinical practice as to how to utilize these drugs, particularly what order to utilize them in. I think there's a lot of really exciting data, as we discussed, toxicity profiles that we now know how to manage so much more effectively. But it'll be very important to help guide providers as to the order to use antibody drug conjugates versus T cell engagers versus CAR T, so that they know how to use these drugs for their patients with relapsed refractory multiple myeloma, while opening the door that if a patient fails one drug, that another future line, they can use one of these other agents. So I just want to thank thank both you, Paula and Adrienne, as well as our guest today, Beth, for participating in today's MedTable Talk. There are several resources that you can download from the activity's website. Join us for the next episodes of MedTable Talk, Episode 2, entitled Navigating the Evidence, Efficacy, and Safety of Current and Emerging Agents, and Episode 3, Creating Patient-Centered Approaches to Care, Best Practices for Utilizing BCMA-Directed Therapy. We hope you found this discussion informative and insightful, and now that you've completed this activity, you may get credit by completing the post-test and evaluation. Thank you.